There's a question that's come, and actually this is interesting. I expected to see this because as of yesterday morning in Ontario, the rules around opioid prescriptions changed. And so instead of the take 62 tablets as directed, physicians are now required to be very specific in the order and the description of how you are to take a medication. If it's an opioid or one of several other controlled substances, they are required to identify the patient with some reproducible identifier, which typically I think will be a health insurance number, because in order to be seen by a physician, we have to look at your health card anyway, or at least our admin people do. So we already know what your health insurance number is, so that's your ID card. That's no big trial for us, but we need to put that on the prescription now. And the pharmacist, when you pick up the prescription, is required to confirm that you are you by looking at whatever the form of identification was that you submitted. So the question here is, I am concerned that the new policy from the Ministry of Health will make my family physician reluctant to prescribe opioids for me. Already there is a call-in for an appointment regarding this. So I wonder, I don't know, Sandra, Andrea, Beth, anyone wish to have in fact, I suspect we could get 3 comments from slightly different perspectives about this.
As a person that lives with pain, I think that the guidelines are good. As Beth...
We differentiate between the Canadian opioid guideline and the new policy from the Ministry of Health, which requires different, that's not a guideline, that's the law. Guidelines are like stoplights in Quebec. You can slow down and drift through them if you want.
I think the new law, although it will be an adjustment, will be beneficial to us because, as Beth said, because of the high incidence of dependence and addiction with narcotics. It has been in effect for 15 years in Alberta, and it is working well. It's going to be adjustment for our physicians, for us, and for our pharmacists to get used to. But I think in the long run, it will be a good thing.
Beth, you want to go?
I just thought I'd explain that the reason for this, these changes are in preparation for the new prescription monitoring program that's coming to Ontario. So this is sort of a first step where this information is needed so that when pharmacists dispense the medications, that information is then available electronically. That's going to go into a provincial database that keeps track of all prescriptions for controlled substances, narcotics and controlled substances. So opioids, benzodiazepines, a few different types of drugs, but particularly opioids. So this is the first step towards implementing or being able to make that prescription monitoring program feasible. And it's anticipated that that's going to be in effect sometime next spring. So, and the prescription monitoring program is a response by the government to this increasing concern around the prescription opioid abuse and addiction. And because a lot of people aren't aware that, I know as being a pharmacist working in community pharmacy, people aren't necessarily aware that every pharmacy has an independent computer system, and so not your prescription data is not shared amongst all the pharmacies in the province. And so there's no way currently for people who are purposely trying to scam the system, you might say, and going to multiple doctors. It's very easy to go to multiple pharmacies, and one pharmacy has no idea what another pharmacy has dispensed. Particularly if they're not using a drug plan, if they're using cash. So the idea of the prescription monitoring program is so that all of these prescriptions can be tracked regardless of how it's being paid for as a public safety measure. It's going to be, as I said, implemented in the spring, and the idea is that then you'll be able to look at rates of inappropriate prescribing or multiple doctoring, that type of thing. And if that does occur, then when the pharmacist is dispensing the medication, there can be an alert come up that warns that this same thing or another opioid was recently dispensed at another pharmacy, that type of thing. So it's to help improve patient safety and particularly targeting that side of the problem where we sort of lose track of where people are getting their medications from which pharmacy. So but the person who asked the question is right, because we know that from other jurisdictions that restrictions or impositions on writing prescriptions does have a sort of a chilling effect, and people may think twice. Most of the experience comes with things like triplicate prescription programs, where in some jurisdictions the prescriptions have to be written on a specific pad, that then this is sort of pre-electronic, where different copies would go to regulators in different places. And we know that the prescribing of those drugs that have those restrictions goes way down, and the prescription of other drugs may go up in compensation for that. And so I think it is a concern that people may think that, but I think that's where the new guidelines and the awareness and really helping people sort of with that destigmatizing sort of attitudes around people who need the opioids chronically versus those who may be running into problems with them, that it really is a problem that we don't ignore, finding that balance. And I think that this new prescription monitoring program is trying to help with one side of that, and hopefully does not have that untoward effect of making the medications less available.
Yeah, and what I was going to say is that it's going to protect those of you who need. And the system is designed to detect those people who are abusing the system, so then we can continue prescribing to those people who really need. But everybody will have to follow the rules. And of course, in the beginning, the physicians are a little confused. We really don't know. Can we put a sticker in the prescription that has all the identifications? Can we fax the prescriptions? So probably if you got a call from your physician, I imagine it's because if you were getting your renewals of your opioids by faxing, the physician was faxing to your pharmacy, probably he's going to call you to get your ID, to put in paper, and then faxing, continue doing the same thing, but now with the appropriate numbers and explaining to you what's happening. That's what I imagine.
So my comment would be I have some of the same concerns as the questioner. Because in my chronic pain clinic, probably a third of the patients that I see come to me for renewals and have been on the same dose for a year or more, and the only reason they come into the pain clinic is because their family physician will not write an opioid prescription. And so the part that troubles me is I don't quite understand that, but part of it has to do with education and getting family physicians comfortable with the appropriate use of medications and appropriate dosing. And I really do have hopes that the Canadian opioid guideline will help to give family physicians some instruction in that regard, and also improved teaching around the use of assessment and management of pain in general, and the appropriate use of opioids will do that. I agree that anything that makes a physician's life even marginally harder is going to steer them in the direction of doing something easier. On the other hand, people are moving more and more towards electronic medical records, and the prescribing program that I had written for the chronic pain clinic currently incorporates all of the necessary information. So it's actually it is no change of practice at all for us to accommodate this new legislation. The difference will be for the patient when they pick it up, they will need to show their identification, and I'm actually, quite frankly, stunned that pharmacies will dispense the things they will without identification. You could pick up somebody else's medication by mistake, quite frankly, because there is no requirement for identification. Or if you're Bob McGillicuddy and Al McGillicuddy is next in line and John McGillicuddy is there and you all have different diseases, there's a McGillicuddy going home with a bag of medication, and it may or may not be relevant to them. So I would have been happier, I have to admit, if a global prescription monitoring system came into place, because I think although opioids are harmful and they occupy some really compelling public press right now, we do at least as much damage with other medications and with medication interactions. And those are the things we need to be very careful of. And BC PharmaNet, for example, has a brilliant universal prescription monitoring system which allows a physician to see every medication that you're on at the time, and it's captured from the pharmacy. So it's not just those that are supported by a pharmacy or by a provincial healthcare system. So it's an interesting piece of information. I think we'll get past it. And the problems that we face in getting appropriate care are pretty consistent wherever we are.
And just, well, I was just going to I was just going to clarify that that's the direction that Ontario is going as well. This is sort of the first step, and with all the, with the technology, they wanted to get this in place, but the goal is with e-health to have that sort of drug information, full prescription information available, but that's, years away.
So in 1988, when I first started prescribing, I loved chronic pain management in 1998 because people would come to me on 3 Tylenol 3 a day and they couldn't manage their pain, and it was so easy because if I gave them 10 milligrams of sustained release morphine twice a day, I was a hero, and they were great. And I still had to deal with the opinion of some of my colleagues that I was a wicked purveyor of Satan's own pharmaceuticals, and that's been a long process, and there is an uncomfortable sense of the pendulum going back in another direction right now from the pain management standpoint.